So thank you very much for the invitation. I very much appreciate to be here. I'm an oncologist, and actually I'm here to show you the clinician's perspective of these new cancer immunotherapies, but I would like to take the opportunity to review recent findings from my laboratory, which is just across the Rhine River, actually. So what we have heard is that cancer immunotherapy has generated unprecedented clinical success. However, treatment failure is still valid for the majority of patients, so we clearly need next generation personalized immunotherapy approaches, and I think combination therapies are one approach to move forward to increase the survival benefit, but also the durability of responses. So it all started basically with William Coley when he injected bacteria into patients, and it took more than a century until we have seen the success of the targeted agents as we see today, mainly with antibodies and with cellular therapies, as we have heard. Now, these are the data that I have brought with me in metastatic non-small cell lung cancer. These are the two randomized trials that show you the superiority of the PD-1 blocking antibodies, not only with regard to the median survival benefit, but also with the durability of the response. And I have to add that the tolerability of these drugs is much better than standard chemotherapy. So what are the pillars of success of immunotherapy? And I highlight a few of them. So first of all, the immune response is specific, as seen by this tetramer staining. And if you target neoantigen, then you can really direct the immune response towards the malignant cell. You can generate a long-lasting response, as evidenced by these effector memory T cells. The immunotherapy is universal, so this is not dependent of driver mutations, as shown here in this antibody response against myeloma patients. And the response is adaptable. So if you think about the breadth of the TCR repertoire, if you think about epitope spreading, for example. So we have learned from Bob Schreiber that we need that tumors are edited, and we need to consider the immunological microenvironment. And there are different hallmarks which are reflected in the microenvironment. One is a tumor-promoting inflammation, and we have and others have described the immunosuppressive phenotype of regulatory T cells. And there are there's active evasion of immune destruction in the immune microenvironment. So we have recently described that metastatic sites have a significantly lower number of CD8 positive T cells compared to the primary tumor. And of course, there is another functional state in the tumor microenvironment, which is T cell exhaustion, and this is a dysfunctional state of T cells, which is characterized by a progressive loss of T cell effector function and by a sustained upregulation of inhibitory receptors. And you have heard that PD-1 is a very famous inhibitory receptor. Now, this is basically the activity of these PD-1, PD-L1 antibodies. Now, as it evolves after ASCO, there is survival benefit now in 4 tumor entities. You see in blue the indications with FDA approval, and these are the 3 FDA-approved antibodies. But I still would like to raise the issue that this is a rather simplistic approach. We just block an inhibitory receptors, and it's still a probabilistic approach. We see, unfortunately, resistance in the majority of patients. This is again a response in metastatic non-small cell lung cancer. And sometimes, we have these durable responses, which is extremely promising, but we also see secondary resistance. So this is a patient of mine that has initially responded, but unfortunately then developed resistant disease. So let's talk about a few key aspects, and I would like to show you data that we have generated in my lab. So let's talk about prediction of response. Of course, PD-L1 is an obvious marker, a biomarker that could predict response. Unfortunately, it is not a good biomarker, and this paper from Yale has shown that it's not. So you have tumor heterogeneity, you have the plasticity of expression, so PD-L1 expression is rather dynamic and depends on interferon gamma. And there are non-standardized test parameters, so there's a discordance of the antibodies that are currently used. So we more focused on the T cells, and these are data from analysis of non-small cell lung cancer. Daniela Tomino, an MD PhD student, she looked on the presence of PD1 expression on these T cells, and she found two populations of PD1 positive T cells. There is this terminal differentiated population which has a PD1 high phenotype, and these are intermediate PD1 expressing T cells. And these have been also described in an LCMV setting by John Wary a few years ago. Now, when we looked into our patients, and you can also track these PD1 high and intermediate T cells in immunohistochemistry, you see that the PD1 high T cells are actually the one that accumulate a lot of other inhibitory receptors in contrast to the PD1 intermediates. And there is an inverse correlation between the rescue of effector function if you use an PD1 blocking antibody and the occurrence of these PD1 high positive T cells. So in other words, the more PD1 high T cells you have, the less you can recover T cell effector functions. And indeed, the PD1 high cells patients are those that have a more advanced stage and have a worse progression-free survival. Now, why is that important? We looked on the activity of a bispecific antibody. These are in vitro experiments, again, taking tumor material from non-small cell lung cancer patients. And what you see is that patients that have these PD1 high these PD1 high T cells, they cannot get activated by these bispecific antibodies, while in contrast, you get a decent activation in patients that have a PD1 intermediate phenotype. So this brings us to a model that along tumor progression, you get more T cell exhaustions, and you upregulate PD1 intermediate. These are the T cells that you can rescue, while PD1 highs, that are T cells that you cannot rescue. Another way to predict efficacy is if you directly test primary tumor material. So we take an artificial matrix and embed the tumor and then expose this to immunotherapeutics, and you see that you get a nice penetration with antibodies. And these are data from a folate receptor DART, data which we have generated together with Christoph Rader from the Scripps, and that you see a nice activation with this DART in primary tumor tissue, and you also can appreciate tumor cell death here in this immunohistochemistry. So let's talk a little bit about efficacy. And again, I go into the field of T cell exhaustion. There are different parameters which are involved and responsible for T cell exhaustion. So just to mention a few, nutrient deficits, there is immunosuppressive cytokines, immunosuppressive population, and others. Now, a observation that we have made already a few years ago is that when you expose these T cells to IL-2, then you get a rapid activation of these tumor-infiltrating lymphocytes. But of course, you are all aware of side effects of systemic IL-2. And therefore, we have applied an immunocytokine. This is basically a targeted cytokine in a genetically engineered mouse model. So you see these mice have basically a loss of p53 and an activated KRAS, and you see this multifocal disease. This model does not respond at all to checkpoint inhibitors, but with this immunocytokine, you get a survival benefit. And when you look into the tumor, you get activation of T cells, of NK cells, and here these T cells are activated, so they start to proliferate and produce interferon gamma. Now, this brings us into the field of combination therapies, and the aim of combination therapies is really not only to increase median survival, but also to increase the durability of the response. And there are multiple combinations possible. FDA and both Swiss medicals have just approved the combination of PD1 and CTLA-4 in melanoma. There is intensive data that some signaling pathways like the BRAF pathway or the beta-catenin pathway interfere with the anti-tumor immune response. And we also have data that if you use HDAC inhibitors or inhibitors of DNA methyltransferase, that you can activate anti-tumor immune responses. So we have worked more extensively on the combination of chemotherapy and immunotherapy, and we have basically come up with data on microtubule depolymerizing agents, so agents that target the microtubuli. And these agents do not only induce tumor cell death, but they drive a phenotypic and functional maturation of dendritic cells. And these dendritics, these activated dendritic cells basically activate the T cell response. Now, these microtubule depolymerizing agents are not applied as free drugs, but they are applied as antibody drug conjugates. And one antibody drug conjugate, which is also available in the clinic, is T-DM1 in HER2-positive breast cancer. So to dissect this mechanism, we took an orthotopic breast cancer model which expresses human HER2, and it's trastuzumab resistant basically. And you see this nice activity of T-DM1, and this is largely dependent on the adaptive immune system. Now, when you treat these mice with T-DM1, you see an upregulation of PD1 and CTLA4 basically on your T cells, and your monocytic populations, these are tumor-associated macrophages, start to express PD-L1. When you treat these mice with checkpoint inhibitors, you have no activity basically, and when you start to combine the treatment of T-DM1 and these checkpoint inhibitors, you get a nice activity. So when you apply T-DM1 twice, then you cure basically all your mice. So to dissect the mechanism further, we went into the immune microenvironment, and what you see is that if you start to treat with T-DM1, you see already some T cells coming up, and when you give the combination, these T cells really enter the tumor islets. You get an inflammatory phenotype, so inflammatory cytokines, IL-1 beta, IL-6 and IL-12 go up. These are chemoattractants, which basically drive the T cells to the tumor site, and you get a strong activation of these T cells, so they start to proliferate, produce to start producing the killing machinery, and you get a Th1 response. Now, we also looked into Tregs, because it has been proposed that once you get tumor rejection, you get a nice decrease of Tregs. However, what we have seen is that we get a massive increase of Tregs, and these Tregs basically are real Tregs. They have a classical phenotype, they are immunosuppressive, and when you deplete CD4 T cells, including Tregs, then you end up with autoimmunity. So you get basically dermatitis and parotitis, which again suggests that these Tregs are necessary and host protective for the anti-tumor immune response. Now, we also wanted to look in patients, and this is a German trial that used breast subtype-specific therapy, including T-DM1 in a neoadjuvant fashion. So people get T-DM1 and then get operated basically. And what you see is that after once T-DM1, you get a nice infiltration with T cells, and this is exemplified here by immunohistochemistry, again suggesting that this mechanism also holds true in patients. And this is the scheme, which is basically driven by the activation of dendritic cells, which direct then the immune response towards the tumor cells. So let's talk a little bit about resistance. So this is a patient basically that received immunotherapy, and when you take a biopsy, then you have a strong upregulation of PD-L1. Now, to dissect the mechanism, we used the mouse model and treated with a CD40 agonistic antibody, and you see this modest activity. This is completely dependent on T cells. And this, basically in this mouse model, you also see a strong upregulation of PD-L1, which is completely dependent on T cells and on the presence of interferon gamma. In the next step, we try to overcome resistance by combining this CD40 treatment with a PD-1, PD-L1 blocking antibody, and you nicely see this synergy, and you can generate a memory response. So when you expose these animals again with tumor cells, then then you have the memory response that is in place. Now, this mainly goes back to CD8 positive T cells, which infiltrate into the tumor and then again start to produce effector functions. And I would like to finish with some words on tolerability. So these PD-1 PD-L1 blocking agents are tolerable. We can manage the side effects. However, there are side effects. So we described this myocarditis in a patient. This was a patient that basically received an autopsy. She clearly died of melanoma, but you see these CD8 positive T cells basically everywhere. This is the lung, this is the bone marrow in the lung, in the liver. So this patient had a generalized autoimmunity. Now you can apply these checkpoint inhibitors in a targeted fashion. This is work that has been done by Keith Malief. We tried, and we are working on applying this in a more targeted fashion. So basically, this is a bispecific approach where you target co-stimulation towards tumor-associated antigens. And even if you take this patient that has a very exhausted phenotype, so you see these PD-1 high T cells, you can nicely activate these T cells if you give this together with a T cell bispecific antibody. So I finish here just to provide a clinical platform and a platform to introduce clinical immunology. We recently founded an immunotherapy platform to develop standard operating procedures. We're also running an immunotherapy board, really bringing immunotherapy into the clinic. And with this, I would like to thank you for your attention. I would like to thank basically my group, all the collaborators. This is just one statement from my previous mentor, Lloyd Old, and I think he was completely true and anticipating the success of immunotherapy. Thank you very much.
In some of your studies where you're looking at the diffusion into the tumor tissue, could you comment about the mechanisms? Do you think it's linked towards the relative affinity to the targets? Do you think it's linked towards more the molecular weight or translational diffusion? Is it easy to extricate the two?
So there are multiple reasons, as you know. I mean, there is a big discussion now about different signaling pathways which promote T cells to get infiltrate. We have not particularly looked into those mechanisms, but in this series that I mentioned, this was a work of more than 4 years where we compared the primary tumor and from the same patients with the metastatic sites and have found a decrease of the number of CD8 T cells. The mechanism is, as I said, complex, and there are different scenarios.
Okay, thank you.